Thank you to the moderators and to SAGES for the opportunity to present. I apologize for the schedule change. I do have to run after this, but I'd be happy to answer any questions that come up on the Facebook forum, or you can email me at the University of Utah. So I will be discussing, again, the role of the surgeon in hypermotility disorders. I have no disclosures. So Dr. Aoyang covered a little bit manometry in the Chicago classification, but I'm just going to review briefly here the hypermotility disorders that I'm specifically discussing in this talk. So the first one is EGJ outflow obstruction, so esophagogastric junction outflow obstruction, and that is related to what we used to call hypertensive LES. In some patients, this can be an incompletely expressed form of achalasia or a very early achalasia, it's thought. In other patients, this may be due to a mechanical obstruction, such as a paraesophageal hernia. I will also touch on diffuse esophageal spasm and jackhammer esophagus, which is similar to what we used to call nutcracker. So these are our new definitions under the Chicago classification of hypermotility disorders. And just to go into that in a little bit more detail, diffuse esophageal spasm is defined or is diagnosed when you have at least 2 swallows on the 10 swallows in the study that are premature contractions or spastic contractions. And the measurement we're using to look at that is called distal latency. A hypercontractile esophagus, which again has been called nutcracker and is now probably more commonly called jackhammer under the Chicago classification, is defined with hypercontractile or high amplitude swallows. So you're looking for at least 2 swallows on the study that have a distal contractile integral of greater than 8,000. And then we have EGJ outflow obstruction, which is similar to hypertensive lower esophageal sphincter. And the measurement that we're looking at for lower esophageal sphincter pressures under the Chicago classification is IRP, or integrated relaxation pressure. And importantly, these patients are differentiated from achalasia patients in that they have normal peristalsis on their study. So these are some high-resolution manometry pictures that show those hypermotility disorders. So in the first picture, you have a premature or spastic contraction that would be characteristic of diffuse esophageal spasm. In the middle picture, you have a hypercontractile contraction, a high-amplitude contraction with a DCI of 1100 that would be typical of jackhammer. And the subsequent pictures show EGJ outflow obstruction, so preserved peristalsis with a high LES pressure or IRP. So what's the clinical presentation here? Well, the most common symptom in patients with hypermotility disorders is dysphagia. Chest pain is somewhat less common than that, but some of these patients actually do present with typical reflux symptoms such as heartburn and regurgitation. So I would like to discuss medical management because I think it's important for us to know all of the options for our patients. However, I will note that it's usually ineffective. But if patients, especially if patients are presenting with typical reflux symptoms or chest pain, a trial of PPIs can be very helpful to see if reflux may actually be the inciting factor for them. Smooth muscle relaxants are often trialed as well, so people can be, have trials of nitrates, calcium channel blockers, or phosphodiesterase inhibitors. Antidepressants have actually shown some utility for these patients, so it's thought that especially jackhammer may have a significant anxiety component in some patients who benefit from antidepressants. It's shown less promise for patients with diffuse esophageal spasm. And then Botox injection I'd like to mention. We know that this is not a durable therapy, but I think that Botox can be really useful in your treatment algorithm, especially as sort of a diagnostic maneuver. If you are considering a myotomy for someone, this may be a useful maneuver first to see if they're likely to respond symptomatically. So now we'll talk about surgical options. First, let's talk about myotomy for spastic motility disorders. This is a little bit of an older study, but Dr. Patty wrote it when he was at UCSF, and they looked at patients who were treated for DES or nutcracker esophagus. This is not a randomized trial, but they had 30 patients who had been treated medically and 10 patients who had been treated surgically at their swallowing center. They were performing thoracoscopic myotomies at that time, and that means that they were able to perform very long myotomies into the chest, and they were also using manometric guidance. So they had their preoperative manometry studies, and they were able to ensure that the myotomies went over the whole length of the spastic area of the esophagus. They found that there was a 20% success rate in terms of symptomatic relief in the medically managed group and an 80% success rate for the surgically managed group. So now I'm going to talk about POEM. In 2017, POEM is a very attractive option because, again, this allows for a long myotomy of the body of the esophagus, if that is a big contributor to this patient's symptoms, without the thoracoscopic approach. So I'm going to highlight 3 papers here that have been published on results of POEM in this patient population. So the first is a multi-center review that was published in 2015, and they had 1-year follow-up in this study. They looked at 73 patients. 9 of them had DES, 10 had jackhammer, and 54 of them had type 3 or spastic achalasia. And Dr. Aoyang is going to be back up talking about achalasia again, so I won't spend too much time on that. But a lot of these studies include type 3 achalasia as one of the hypermotility disorders that they're looking at. Their mean myotomy length was 16 centimeters, so quite a bit longer than you would normally get with a Heller. And they looked at outcomes including dysphagia and chest pain relief, as well as manometric studies, and they found that those were all improved after POEM. They did note that there was a lower symptomatic response rate for patients with jackhammer compared to the other disorders, but it was still, pretty reasonable at 70%. So another study that I wanted to highlight was from the Oregon Clinic group. They published a report looking at POEM specifically for hypermotility disorders, and they had 12 nutcracker patients, 5 with DES, and then 8 with hypertensive LES. They found that dysphagia relief was better for those with the type 3 achalasia than those with the other hypermotility disorders. They did report on chest pain, which I think is important because chest pain can often be a very difficult symptom to treat and resolve in these patients, and they published very good results for chest pain specifically. Of note, their follow-up for this study was 6 months. And then there has been a meta-analysis published this year, which no doubt includes data from the studies that I just went over. This combines 8 observational studies that have been reported looking at, again, type 3 achalasia, DES, and jackhammer. So you can see the total N there for the meta-analysis of these are rare disorders. And the endpoint that they were able to report was improvement in dysphagia. So in this meta-analysis, they were not able to report on chest pain, since presumably not all of these studies had included those data. But they found for dysphagia that the success rates for these disorders respectively was 92, 88, and 72%. So now I'm going to do a complete 180-degree turn, or 360, if you will, and talk about fundoplications for hypermotility disorders. Bear with me for a couple minutes, and I'll try to explain how this works. But at the University of Washington, they looked at patients who had had high-resolution manometry at the swallowing center there. They identified 221 patients who had these hypermotility disorders. Of those, almost half of them had actually also had an abnormal pH test. So this is a group of patients, a subset of patients, who had pathologic reflux on a pH test. About 2/3 of those actually had a Nissen fundoplication, and this is a retrospective study. So then they looked at the group of those patients who had at least 6 months of follow-up, and they found that all of them exhibited symptom improvement, and of the small number who had had repeat manometry, almost all of them had actually normalized their hypermotility disorder. So this makes no sense. I just spent 3 slides talking about POEM for hypermotility disorders, and now I'm talking about fundoplication. So how do we use this clinically? Well, the key here is really a thorough workup preoperatively and patient selection. So in this study, the patients were primarily presenting with symptoms of reflux, so heartburn and regurgitation. And what they found on their review was that the patients who were presenting primarily with reflux symptoms usually had an abnormal pH test. In contrast, patients who were presenting primarily with dysphagia or chest pain usually had a normal pH study. So I think that this really highlights the importance of doing a thorough evaluation of esophageal physiology before making decisions, and also of listening to the patients and really finding out what their presenting complaint is and what their most bothersome symptoms are. So in conclusion, spastic motility disorders are challenging to treat, and they're rare, but there may be a role for surgery for these patients. POEM seems very promising, but the results are still early. Pathologic reflux is something to keep in mind. We think that in a subset of these patients, reflux may actually be the inciting factor for their motility disorder, and so that should be treated if present. And I would definitely recommend a multidisciplinary evaluation and treatment planning team for these patients, because these are challenging patients to treat, and they're rare. Thank you very much.